Hello, I am Mansi Gawali,
Hi,
one of the medical student. What is your name?
Madhukar.
Okay. So today we are going to examine your abdomen. Do you have any abdominal pain?
No.
Okay. So now we'll start your examination.
To begin, explain the steps for examining the abdomen to the patient and locate a good light. The patient should have an empty bladder. Pay special attention when draping to expose the abdomen. Tips for examining the abdomen. Make the patient comfortable in supine position with the pillow under the head and perhaps under the knees. Slide your hand under the low back to see if the patient is relaxed. Draping the patient. To expose the abdomen, place the drape or sheet at the level of symphysis pubis. Then raise the gown to below the nipple line just above the xiphoid process. Warm your hands and stethoscope. To warm your hands, rub them together or place them under hot water. For inspection, inspect the surface, contours, and movements of the abdomen. Watch for bulges or peristalsis. Note the skin, including temperature, color, scars, striae, dilated veins, or rashes. For umbilicus, observe its contour and location and any inflammation or bulges suggesting a ventral hernia. For peristalsis, observe the abdomen for several minutes if you suspect intestinal obstruction. And for pulsation, the aortic pulsation is frequently visible in the epigastrium. Auscultation provides important information about bowel mobility. Auscultate the abdomen before performing percussion or palpation maneuvers which may alter the characteristics of the bowel sounds. Place the diaphragm of your stethoscope gently on the abdomen. Listen for bowel sounds and note their frequency and character. Normal sounds consist of clicks and gurgles occurring at an estimated frequency of 5 to 34 per minute. If patient has hypertension, auscultate the epigastrium over the aorta. Then auscultate the iliac arteries and the femoral arteries. Auscultate over the liver and spleen for friction rubs. Percussion helps you assess the amount and distribution of gas in the abdomen, viscera, and mass that are solid or fluid filled, and the size of the liver and spleen. Percuss the abdomen lightly in all four quadrants to determine the distribution of tympany and dullness. Now, palpate four quadrants of abdomen, beginning with gentle palpation for detection of abdominal tenderness, muscular resistance, and some superficial organs and masses. Keep your hand and forearm on the horizontal plane with fingers together and flat on the abdominal wall. Palpate the abdomen with light, gentle dipping motion. As you move your hand to different quadrants, raise it off the skin. Gliding smoothly, palpate all four quadrants. Then, using the palmar surface of your fingers, press deep in all four directions. Identify any mass, note their location, size, shape, consistency, tenderness, pulsations, and any mobility with respiration or pressure from the examining hand. To assess possible peritonitis, ask the patient to cuff and identify where the cuff produces pain before palpation. Then palpate gently, starting with one finger, then with your hand to localize the area of pain. As you palpate, check for peritoneal signs of guarding, rigidity, and rebound tenderness. For percussion, measure the vertical span of lever dullness in the right midclavicular line after carefully locating the midclavicular line to improve your accurate measurement. Starting at the level well below the umbilicus in the right lower quadrant, percuss upward towards the lever. Identify the lower border of dullness in midclavicular line. Use a light to moderate percussion strike because the heavier strike can lead to underestimates of lever size. Next, identify the upper border of lever dullness. Starting at the nipple line, percuss down to the midclavicular line until lung resonance shifts to lever dullness. Now, measure in centimeters the distance between 2 points, which is known as the vertical span of lever dullness. For palpation, place your left hand behind the patient, parallel to and supporting the right 11th and 12th ribs and adjacent soft tissues below. Remind the patient to relax on your hand. By pressing your left hand upward, the patient's liver may be felt more easily by your examining hand. Remind the patient to relax on your hand. By pressing your left hand upward, the patient's liver may be felt more easily. Place your right hand on the patient's right abdomen lateral to the rectus muscle, with your fingertips well below the lower border of the lever dullness. Ask the patient to take a deep breath. Try to feel the lower edge as it slides down to meet your fingertips. When palpable, the normal lever edge is soft, sharp, and regular with smooth surface. Stand to the right of the patient's chest. Place both hands side by side on the right abdomen below the border of lever dullness. Press in with your fingers and up towards the costal margin. Ask the patient to take a deep breath. The lever edge is palpable with the finger pads of both hands. For assessing percussion tenderness of a non-palpable lever, place your left hand flat on the lower right rib cage and gently strike your hand with the ulnar surface of your right fist. Ask the patient to compare the sensations with that produced by similar strike on the left side. For percussion of spleen, two techniques may be helpful. In the first one, percuss the left lower anterior chest wall roughly from the border of cardiac dullness at 6th rib to the anterior axillary line down to the costal margin, an area termed Traub space. In the next one, check for a splenic percussion sign. Percuss the lower interspace in the left anterior axillary line. This area is usually tympanic. Then ask the patient to take a deep breath and percuss again. With your left hand, reach over and around the patient to support and press forward the left lower rib cage and adjacent soft tissues. With your right hand below the left costal margin, press in toward the spleen. Ask the patient to take a deep breath. Try to feel the tip or edge of the spleen as it comes down to meet your fingertips. Note any tenderness, assess the splenic contour and measure the distance between spleen's lowest point and left costal margin.
We'll examine your kidney. Warren.
The kidneys are retroperitoneal and usually not palpable. For palpation, move to the patient's left side. Place your right hand behind the patient just below and parallel to the 12th rib, with your fingertips just reaching the costovertebral angle. Lift, trying to displace the kidney anteriorly. Place your left hand gently in the left lower quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant just below the costal margin. Ask the patient to breathe out and then stop breathing briefly. Slowly release the pressure of your left hand, feeling at the same time for kidney to slide back into its expiratory position. If kidney is palpable, describe its size, contour and any tenderness. Alternatively, try to palpate the left kidney using the deep palpation technique similar to the palpation of the spleen. For palpating right kidney, use your left hand to lift up from the back and your right hand to feel deep in the right upper quadrant. Proceed as before. The kidney may be slightly tender. If the kidneys are tender to palpation, assess percussion tenderness over costovertebral angles. Pressure from your fingertips may be enough to elicit tenderness. If not, use fist percussion. Place the ball of one hand in costovertebral angle and strike it with the ulnar surface of your fist. Use enough force to cause a perceptible but painless jar or thud. To assess the aorta, press firmly deep in the epigastrium, slightly to the left of the midline and identify the aortic pulsations. Assess the width of the aorta by pressing deeply in the upper abdomen with one hand on each side of the aorta. Detection of pulsations is affected by abdominal girth and diameter of the aorta. Percuss for dullness outward in several directions from central area of tympani. Map the border between tympani and dullness. Test for shifting dullness. Percuss the border of the tympani and dullness with the patient supine. Then ask the patient to roll on one side. Test for fluid wave. Ask the patient or an assistant to press the edges of both hands firmly down the midline of the abdomen. This pressure helps to stop the transmission of wave through fat. While you tap one flank sharply with your fingertips, feel on the opposite flank for an impulse transmitted through the fluid. Ask the patient to point where the pain began and where it is now. Ask the patient to cough to see where the pain occurs. Palpate carefully for an area of local tenderness. Classically, McBurney point lies 2 inches from the anterior superior spinous processes of ilium on a line drawn from that process to the umbilicus. Palpate for rousing sign and refer rebound tenderness. Press deeply and evenly in the left lower quadrant. Then quickly withdraw your fingers. Assess the psoas sign. Place your hand just above the patient's right knee and ask the patient to raise that thigh against your hand. Alternatively, ask the patient to turn on your left side. Then extend the patient's right leg at the hip. Flexion of the leg at hip makes the psoas muscle contract. Assess obturator sign. Flex the patient's right thigh at the hip with knee bent and rotate the leg internally at the hip. This maneuver stretches the internal obturator muscle. Put your left thumb or fingers of your right hand under the costal margin at the point where lateral border of rectus muscle intersects with the costal margin. Alternatively, palpate the right upper quadrant with fingers of your right hand near the costal margin. If the lever is enlarged, hook your thumb or fingers under the lever edge at a comparable point.